As I mentioned in the previous lecture, I want to look separately at the actual building of St. Christopher's Hospice, and this is the moment when all of those years of preparation, almost 20 years of preparation, led to the actual building of the first contemporary hospice. And so a number of aspects about this influenced the way the whole movement for hospice and palliative care rolls out over time. Although, as I have said before, it changes in the different countries in which it goes, of course, because it's in a different landscape, but nonetheless, there are some obvious similarities based in how Cicely Saunders went about it, and the fundraising, the architecture, all of those things have an ongoing influence on the whole movement. In his chapter looking at precursors to contemporary hospice, David Clark looks at a number of different institutions around the world in his book To Comfort Always on the History of Palliative Care. And one thing that he notes, which I think will come as no surprise at this point in the course, it's women everywhere. So almost all of them, all the ones he's noting here, are founded by women, and we've had some discussion about why that might be the case. And almost all of them, if not all of them, were founded either by religious orders or charities or both. And I think that underlying foundation makes complete sense because this is such a challenging field to move into. It's not something that somebody would wake up in the morning when they're thinking about a job and think, this is what I'm going to do. It would have to be coming from some other source. And so what we see with these women is they're almost all religious of some kind, sharing religious beliefs of some kind. So I'm showing a picture here of a hospice in Ireland, in Wicklow. And so this group is the Irish Sisters of Charity. And so one of the most important women in this group is Mary Aikenhead, who was born in 1787 in Cork, Ireland, and became Sister Mary Augustine at age 25. So she went to train in France. So she went to Paris to train at a hospital there. And so, as I've said before, I haven't been able to locate good research on these orders, but there is no doubt that France plays a central role here. And so I hope somebody's writing on this. And in terms of a PhD, I don't mean any of you don't have to write on this, but that there's research being done. So so we see France really important here in terms of training a lot of these orders of various kinds of nuns. And you've already seen the case of the influence on New France and North America. And so this is happening all around Europe as well. And so Mary Aikenhead goes to train in Paris, and then she brings back her knowledge and founds St. Vincent's Hospital in Dublin, and then she goes on to found Our Lady's Hospice for the Dying in 1879. And it starts out as a 27 beds. And so we can see the model coming out here that this is a smaller institution than a typical hospital, and that becomes the ongoing model. Most hospices are actually smaller than 27 beds, but it depends on the location. So we see that model beginning to emerge of a certain kind of focused care on the terminally ill, often the terminally ill who are also impoverished, and that it's done in a small scale kind of institution. Now, Clark also includes the example of Rose Hawthorne, who was actually the daughter of the very famous writer Nathaniel Hawthorne. Some of you may know him. She was born in Massachusetts in 1851. She actually ended up converting to Catholicism and then began working with poor communities in New York's Lower East Side. So it's said that she opened the first home in America for free care of incurable and impoverished victims of cancer. So again, hospice, in the case of Cicely Saunders, emerges very much out of cancer care. Now, of course, it has expanded and it is just all end-of-life care. But in the beginning, there was a real focus on cancer care. And I'm assuming it's partly because cancer can be a long-term condition, and also it can be very painful. So dealing with that was one of the first concerns of hospice. And then he goes on to look at a number of different terminal care homes in London, including the one in which Dame Cicely Saunders worked, so St. Joseph's and St. Luke's. So we see these models, we're starting to see these models of terminal care homes of various kinds in places like Australia, in the US, in Canada, in the UK, in France, often run by religious orders or very religious people. And so this becomes, and some of these, the ones in Ireland still exist, and so these become a very important model for how it's built in the contemporary period. The image here is of the beginnings of a site plan for St. Christopher's Hospice. So this is dating to 1962, and I've drawn it from the archives, that website that I posted for you on Blackboard. And when I was researching in the archive, I did come across these documents, and it just felt incredible to hold it in your hands, which is the beginning of this huge, huge movement, essentially. And so this is when things are starting to get really, we're getting close to getting shovels in the ground. And so on the archive, it notes that one thing Cicely Saunders knew, even though her ideas were constantly evolving with new information and new challenges, that there was a need for a new space. So they write, since the 19th century, hospitals were built to be highly functional and efficient spaces, allowing for classification of disease, and the role of the bed changed from being a private place to one of increasingly professionalized investigation. The clinical gaze required an increase in levels of hygiene, lighting, and observation, rather than the traditional notions of rest and comfort, and resulted in the concomitant loss of patient dignity, privacy, and individual status. The popular Nightingale wards, long open spaces with 30 beds arranged up and down the room, became a standard ward layout of the late 19th century and contributed to influence hospital design in the 20th century. So this is saying that hospitals, modern hospitals anywhere, were built with a very particular idea in mind, which is, as we've talked about already, curing people. And so it's much more focused on ability to see clearly, good hygiene, all of these things. Not that those aren't important, but this certainly, it's a less personalized environment. And so they also note in the archive that in this setup, death is seen as a kind of failure because you're trying to cure the person. So death can be seen as a kind of losing in the fight. So there's a whole change of attitude, and that change of attitude impacts how the site is built. And so we're beginning to see it. It doesn't happen for a number of years yet, but the idea that hospice architecture is going to look quite different than hospital architecture. And so related to this is the idea that sites have feeling. And so, as it says in the archive, whatever the type of space, it is through this engagement with or being engaged by particular spaces that their status shifts. They are transformed from mere physical areas into places through being endowed with meaning and significance. So right from the beginning, Saunders is aware that the way she's going to build this or have this built is going to impact on the people in the space, both the people working there and the people who are the patients. And so it's interesting to see how she struggles here. And I think this is so important because I think biographies of important people are often presented like they're this lone genius and they came out with this amazing idea. But what we can see very clearly with Saunders is she was struggling all the time to clarify what this new thing was going to look like. And so, for instance, I'll just give an example. She was offered land attached to a pre-existing, that was going to be, was a hospital site on Denmark Hill, very near to where actually the hospice was eventually built. But as tempting as this was, she refused this, and partly because she wanted autonomy. And at this time anyway, she wanted the hospice to be outside of the national health, so the kind of socialized health medicine that's like our OHIP. She didn't want it to be part of that. Now, this starts to change, and we certainly see in the Canadian case, hospice and palliative care have become more and more in alignment with our medical system. But I think because this was the first one, she was very aware that she could get bogged down in bureaucracy or the rules of the hospital or the oversight of the hospital. So she decided against taking them up on their offer, but she stayed very, very closely associated with King's College, which she was an alumna of, and they claim her very proudly. They've got a big picture of her outside the building. So she's very tightly maintaining this network, but she's establishing the independence of this hospice, and this becomes very important for her. Here's an image of Cicely Saunders on the site that is to become St. Christopher's Hospice. I'm not sure who the man is. It may be her brother, but anytime I've come across this photo, it doesn't tell us who he is. So we're told in her biography that she started to apply for funds. Now, funds and hospice, anyone who knows the sector knows this is always an issue. And so especially if you're not operating within the hospital system, you're having to fundraise. And so this was part of her challenge from the beginning, and even into once it had been built. And so she applied to the King's Fund. And at this time, her brother John, like her father, was also an estate agent, rang to say he thought he had found a suitable site in Lowry Park Road in Sydenham. The asking price was £27,000. So as I had said earlier, her brother here, all of her kind of personal networks are part of this. So the brother finds the place, she goes down to look at it, and it was a site where there had been houses, but they'd been demolished, and it's in a kind of a suburb of London, and it's not separate in that sense. And so we can see with St. Christopher's, it's very much of its place, and I'm always struck as I have studied Saunders. She's a Londoner, and she wanted the hospice to be part of the life of London. It's on a bus route, that it's convenient for people, that it's part of the life of the neighborhood. And we're going to see, when I look at Nipissing Serenity Hospice, they take a slightly different angle, and I think it's a very Canadian angle where they want it to be in nature. It's a little bit apart. It's still in the town, but it's a little bit apart. It's on a river, and so I think it's very important to note that for hospices, they're very of their place. They're very localized, and to me that makes perfect sense that would be the case. And so. So she's waiting for this money from the King's Fund, and anyone in fundraising knows, and I have so much respect for people who do fundraising, it's an incredibly difficult thing to do, that the first big check is the important one. Often if someone gives money, then other people will give money. So she knows how important getting this money is. And so so we're told that she had I love this. She had the patients at St. Joseph's praying like beavers, and she was praying that this would come through properly, and it would. So according to her biographer, as usual, she read her daily light that morning to find the text was, "Thou shalt be blessed, the Lord thy God, for the good land which he hath given thee." So as she instantly knew, God was on her side. At 5 o'clock that evening, Mr. Halton from King's Fund rang her at St. Joseph's, telling her that she could have up to $30,000 to include the cost of purchase. The patients had been asking her all day if she'd heard anything. Mr. Petit was the first person I could tell. He was the nearest to the phone. I remember saying, "We've got it, we've got it." And he died only 5 days later. And I remember saying to him on that last afternoon when he looked at me shaking his head, "I'll never, never forget you." So I find that this makes sense for what we know of her life and belief, that she's including her patients in this process as she considers them to be just an integral part of the development of the vision, and they're a huge part of what's motivating her. So so we see she gets that money. Now part of the kind of the conditions of that money is it cannot be explicitly religious. And so we start to see this moves hospice into a track that's in the secular realm. And some of this was just for practical reasons, but certainly it allowed for the model to travel internationally, because many, including the Canadian system, would only give money if it's a secular enterprise. And so fundraising, as many of you will know, is ongoing, and so it's typical for hospices to do runs, walks. In the case of St. Christopher's, they have a charity shop, and so on. But what I do think is remarkable about fundraising for hospice is it's one of those things that it's often quite easy to fundraise, or easier, because it's within the realm of people's understanding of kind of charitable giving, and so you don't. Often I find it's like I had a fundraiser come from sick kids. You're like, okay, like you don't need an explanation. So because it's important work. And so I do think, combined with her charisma and her commitment, that this also facilitated the fundraising. But even into the present, it's not as hard to sell as certain other kinds of fundraising. And so she set the example of being very, very proactive in bringing money to the hospice. So in terms of the wards, obviously Saunders was very familiar with different types of hospital setups and different types of end of care setups, including Our Lady's Wing. And so she envisioned 3 terminal wards, a mixture of 6 and 4 beds, providing a total of 16 to 20 beds. So you can see that's fairly small. In addition, there ought to be 3 single rooms to provide privacy and intimacy. Now, again, this evolves over time, and I certainly know in the Canadian case, because of the way Canadian society is, there's an increasing movement towards private rooms. We see that in all institutional settings, including residences. Some of you may not know, but back in the day, you would put 4 people in a room in a residence. Now people just won't go for that. So we start to, at least in the beginning, it was the idea there was more than one person in the ward. And she was very clear there had to be a lot of natural light. And the idea that grows that you can move the bed around, and in many cases now in contemporary hospice, you could take the person outside. And so we see also her trying to minimize the clinical gaze. So the idea that the nurses obviously should be able to see the patients, but it shouldn't be this idea of kind of surveillance. It should feel much more like a home setting. And so you're needing all the things that you would have normally in a hospital, but a much more of a sense of it being a more home-like situation. And so I'm showing this picture here to give some sense of it. So you can see there's aspects of it that very much look like a hospital, but even just the fact that the family and the extended family are being welcomed into the hospice. They're sitting on the bed there, and so you can see the person is part of the flow of life still. And so the whole idea being that, of course, you have to make care at the center, but you also have to put family visitors at the center as well. Here is a more contemporary image. You can see again, it has some of the typical hallmarks of a hospital room, but there's art on the wall, there's flowers, people can have their own knickknacks around if they want. There's color, there's natural light looking out onto nature. And so at St. Christopher's, there is, when you go to the back, it opens out onto this beautiful garden, which is again very English, the idea of a beautiful garden. And so people can sit out there with their family, or the nurses can sit out there and have lunch, and the doctors. So this idea of something that's more intimate. And so in the archives, it says, the purpose-built hospice sought to change the experience of the time close to death. Distress, fear, and loneliness will disappear, and a time that can be so hard and so dreary would be transformed into one of peace, security, and meaning, a sort of homecoming. So that to me says it all, that idea that you're in a home-like environment. And we're going to see that palliative care develops out into also offering care in the person's home. But if they're not able to be in their own home, then at least they're in a much more home-like environment. And so, so right from the beginning, we see this coming together of science and technology and all the most up-to-date forms of medicine, but also really putting that patient and their family at the center, and the atmosphere around them being very important here. Unsurprisingly, as Saunders had been a nurse and was a doctor, she was very aware of the needs of the medical staff within the hospice and designed it in that way so that it would be as efficient and comfortable for them as well as for the patients. I like this picture. I think it says a lot, and it's my own experience. I do think it's the staff in hospices, there's a different kind of vibe, because you're not obviously an emergency room, you're trying to save lives, your sole purpose is that. So it's a different emphasis. And so we can see, I think this also highlights the idea of a team, an interdisciplinary team, which you can include social workers, clergy, chaplains, researchers. And so we can see here that it's pretty clear that that sort of old-fashioned hierarchy of doctor and nurse is less so, and that is definitely part of hospice and palliative care, and the idea that hierarchy is broken down to some extent. I'd be interested to hear from those of you who work in healthcare how true that is, but that was certainly the idea, that there was mutual respect, interdisciplinary team at the heart of hospice care. So I'm ending here with an image of St. Christopher's Hospice and the exterior, and this only continues to grow over time. And I just noticed online that there's been right from the beginning, Cicely Saunders wanted it to be a research and education center, and so there was a whole part dedicated to researchers who could come and work there. But there's now a separate building, and this was another reason she wanted to be separate from the hospital. She wanted a kind of a campus, and so to have enough land that this could take place. And so there's now a completely separate, very beautiful, very carefully built building dedicated to research and teaching hospice and palliative care. And so it's interesting to me, she did choose modernist architecture. She chose the architect Peter Smith. So if we think back to that first image of, it was a much more traditional looking building, she didn't want that. So I find that interesting. And so that definitely imprints on hospice, and any of the ones I know, they're quite modernist in the way they're built. That said, they definitely take on board. They're not completely horrible like a lot of those 60s buildings. So there's a lot of emphasis on natural light, and I'll talk about this more when we speak specifically about when we look at specifically at the architecture of hospice.